we are talking about a very important topic, which is supporting patients in tapering off of benzodiazepines. Can you tell us a bit about your background and what you do?
So thank you again, Nishi, for inviting me, first of all. I'm a board certified psychiatrist, and I believe actually I graduated 10 years ago, now that I look back last month. So I graduated from Temple University, then I did some work in inpatient psychiatry, but right now I am full-time outpatient psychiatry here in Nevada, Reno, Nevada. And I do this work on the side. It's a passion, teaching all the other medical professionals who are interested in psychiatry right now. We have a website called Psychiatry Education Forum, and our main actually I created this website mainly to teach myself, to see what's happening, and then few people were interested, and that's what resulted in birth of our website right now.
It's a great platform. I've been following you guys online and I love what you're doing and I love learning from you. And it's so funny. That's how I started my sleep education platform. It's what I would have wanted. And so then other people we can all benefit from learning from one another.
100%.
Yes. Our topic is the benzodiazepine tapering process. And we're talking about some of the new guidelines. Why is this such a hot topic? And why is it such a clinical challenge for physicians and other health practitioners?
So this is so interesting, right? I was reviewing some data before I created this course from the guidelines. FDA did some analysis in 2020 and they found close to, I'm not getting the right number, close to 92 million benzo prescriptions were prescribed that year in 2020. So that's why this is such a hot topic, both for physicians and our patients, because the problem is the risk of dependency is so high with these medication class compared to others. So the withdrawal risk is high for that reason. And this was actually a new information for me when I reviewed these guidelines. They said in 3 weeks, 2 to 3 weeks, the dependency risk can happen depending on the patient's profile. So that's the number one reason. And second is the withdrawal that happens. They can very closely mimic the symptoms or the disease or disorder it was given for, so very difficult to differentiate. And obviously, for a good reason, the patient fear around this tapering or reduction. So I feel this is the main reason I believe ASAM took so long to come up with this new guideline a few months ago.
Yeah, and I think the patient fear is a big one, and that's where some of our soft skills come in supporting patients. So we're going to talk about that and how to do that effectively. What are some of the biggest misconceptions that doctors and clinicians have about tapering benzos?
So first of all, I want to say that all the medical professionals, our intention is very positive. Nobody's doing anything to harm patients. But the most important misconception I will talk from my side is we all believe that all the patients who are on benzos for a long time should be tapered right now. That's how I used to feel before I read every page of this guideline. And number two is we all feel, now I should not talk about everybody, but one of the misconceptions is that we should taper these medications faster. But the guidelines emphasize a lot the benefit of slow and steady taper. And the last is, and this is actually, I was not able to find right answer from the guideline, is that we should switch everybody to long-acting benzodiazepine before we start switching, which is not the case for every patient. We have to look at many things that I will talk about in a few minutes, but it's a whole patient profile we need to look after before jumping into if taper is needed, or maybe first switch them to long-acting benzos.
And I think that first point that you made, that one of the big misconceptions is if you have a patient on long-term benzos, we need to get them off yesterday. And I see this discussion all the time in physician Facebook groups, especially in the psychiatry Facebook groups. So at what point do the risks of continuing to prescribe outweigh the benefits of tapering?
Yeah, that's actually a very complicated question. But what I will do is to make it easy, I will share a few slides from our course. Hopefully that will make it easy because I like to draw things, and in these slides I have created a few of them. Can you see my screen now?
Yes.
Perfect. This is the course that we just released in our academy, and this is the most recent guidelines released by American Society of Addiction Medicine, ASAM. And before I go into that risk and benefit analysis, I just want to touch very briefly on something that the guideline talked about in terms of what these guidelines are and what these guidelines are not. So this guideline is mainly to help all the healthcare professionals who prescribe benzos like us. And it's not for children or adolescents, it's mainly for adults right now, ranging to geriatric population. And the core purpose is to support individualized patient-centered care for benzodiazepine tapering. And this patient-centered approach word that we see right now, this is the biggest message I got from these guidelines, that this is a patient-centered approach, and we will talk about that in a minute. But more importantly, we need to know that these guidelines are not for palliative care, where benzos are used appropriately. And it's not for patients who are on less than 2 weeks of benzos or using on as needed basis. Now, that's why the guideline says even 3 weeks of benzodiazepine daily usage can increase the risk of dependency and thereby withdrawal. And it's not to replace our clinical judgment. This is the biggest thing I saw when these guidelines came out. Not everyone, most people jumped into that, oh, we should taper everybody off benzos. No, it's a clinical judgment. It's not replacing our clinical judgment. It's just an add-on to that. And it's not a rigid protocol. It's not designed that, oh, you need to do it right now. And it's not one size fit all, which I will talk about in a few minutes. And this is not a law, this is not a regulation, this is not a mandate. Please be mindful of that. And this is not exclusive to patients who have substance use disorder. Now, I'll just move forward. But to your question, Nishi, you said like the risk and benefit assessment. This is the basic backbone of these guidelines. Like they have a very big flow chart for 3 pages. The first thing is to assess the risk and benefit for our patient. And the guidelines recommended that we should assess this at every 3 monthly follow-up, but you should assess that at every new benzodiazepine prescription or every time you're renewing it. And that's where the PDMP and all those state mandated, I forgot what the word is, the online websites we have now to look at how often they are filling and who is prescribing these medication comes into picture. And this is a strong recommendation. The strong recommendation per ASAM guidelines means that benefit outweighs risk, and this has to be implemented. That's what the strong word means in this guidelines. Now, this is what I personally do with my patients, and this is the chart that I use, which is talking about both the benefit of continuing benzos and the risk associated with benzo use and benzo taper. And I will very quickly go over them in less than a minute. The benefit of benzodiazepine use is it's effective in managing our patients' mental and physical health. It's helpful in improving their functional status on a day-to-day basis, and it improves their quality of life. That's why when they talk about that patient collaboration, that gives us an opportunity to do 2 things. First, talk about the benefit and risk this table, and also to listen to our patients in terms of what are benzodiazepines doing for them in terms of functional improvement and quality of life and everything. But the risk is where we can't ignore things, right? We should never go with benefit alone. It's a benefit and risk. So risk associated with the use of benzodiazepine, we all know it. Oversedation, especially with polypharmacy that we see with drug usage, alcohol use disorder, and especially with the co-prescription of these opioids. This guideline talked a lot about the patient population who are co-prescribed opioids and benzodiazepine. This oversedation risk, respiratory depression, impacting sleep more negatively, and all that comes into picture. We can't ignore that, especially in elderly. And then fall and related injury with benzos, memory impairment, cognitive impact. Now there's a big buzz now on the risk of early onset of dementia. We have actually, we recently did a journal club for our academy. So the studies are so conflicted. There are studies on one side which proves it so clearly that it does, and the most recent studies are not, but we can't ignore the risk in any way. And then obviously motor vehicle accident risk going higher with the benzo usage. We talk medication interaction that we just mentioned briefly, impact on their co-occurring mental and physical health condition, disrupted sleep patterns. I know this is more of your area, Nishi, but this is such a big thing with the use of benzos. Impact on their other areas of life, work, family, risk of diversion, substance use disorder. But this is with the benzo usage. But the risk also increases with benzo taper, which is the withdrawal symptoms, which we will talk in a few minutes. Most people get mild, but the risk of severe and complicated withdrawal is a very big thing. But there was a new term I found after reading this guideline. There is something called protracted benzodiazepine withdrawal syndrome, which is like patient continues to have these symptoms beyond 4 to 8 weeks, and it can even last for years for some people. So we can't ignore that. And then obviously recurrence of condition for which we have prescribed the benzodiazepine for. And then impact on their mental and physical health condition, protracted withdrawal that I just mentioned, return to illicit benzodiazepine usage or transition to illicit benzodiazepine usage. So we have to review this benefit and risk with the benzodiazepine usage and taper. And this is the most important statement I felt they mentioned. So I will just read it directly, or I will just read the last line, that we should not assume that tapering is right choice for all patients, right? We have to do the risk and benefit ratio at every visit, minimum every 3 monthly. And this is the table that I was mentioning. I have created like few slides on that. So the algorithm starts with this. Is risk outweighing benefit? If it is not, please continue the monitoring and you don't need to take an immediate step of tapering right now. But if the risk starts to outweigh benefit, that's when we need to start the taper. And I will just stop the sharing and perfect.
Thank you so much. That was so helpful. And I really like just seeing things laid out. I think it makes it very clear because, again, this is a nuanced topic. It's not just that, okay, your patient's on benzos, now we have to taper them off quickly. And I'm really glad you mentioned the protracted withdrawal. So I'd like to, as we continue this discussion, to address that piece as well. Now, you mentioned drug interactions. So could you talk a little bit more about that, some of the cytochrome P450 interactions that we need to be on the lookout for?
Yes, so let me actually go back to my slides very quickly. And the reason I'm using these slides is this is really helping me when we talk about these. Oh, actually, I forgot to mention, you see this one and everything mentioned here. So this guideline have total 28 recommendation. We are still on the first recommendation right now of risk and benefit analysis. And in that, they talked about medication review. And I will not go into detail, like we talked about the PDMP review to look at what the drug interactions are happening right now. But not only the risk of additive interaction, we need to look at the drug interaction from cytochrome P450. And I will just briefly touch base on that because this was a new learning for me, or maybe I forgot what we learned in residency. But cytochrome P450 system plays a very big role with benzodiazepine. This is all from the guidelines, so I'm not making this up. And this is guidelines actually talked about these benzos right now. And this is so interesting. All the benzos goes through only 4 cytochrome P450 system here: 3A4, 2C19, 2C9, and 1A2. And these first 5 benzos, alprazolam, which is Xanax, clonazepam, which is Klonopin, and then triazolam, chlordiazepoxide, and estazolam, they all go through 3A4 alone. They have no impact or major impact on the other 3. Following this, the other 2, flurazepam and clorazepate, they also go through 3A4, but 2C19 gets involved. Now, clonazepam have these 2 plus 2C9, and the longest acting benzodiazepam has actually all 4 involved. So the basic message we are getting here is the 3A4, this one. All benzos goes through 3A4. So the message here is, if a patient is taking any medication that is a 3A4 inhibitor or a 3A4 inducer, it will impact our benzodiazepine, right? Mainly inhibitors, because Increasing benzodiazepine is where the problem starts to happen from the oversedation, fall risk, cognition, and then also increasing the risks of dependency for that. So we all know major 3A4 inhibitors, especially the fluoxetine and those ketoconazole, those antifungals and certain antibiotics, we need to be mindful of that. And even grapefruit juice is a 3A4 inhibitor, so I always educate patients on that. And 3A4 inducers will reduce it, like carbamazepine, the Tegretol, so be mindful of that. But the question always comes, if every medicine is going through 3A4, then what options we have if we have to do something with 3A4 inducing or inhibiting medication? That's where the mechanism outside cytochrome P450 system comes into picture, and that is the glucuronide conjugation through the UGT system. And we have three benzos that goes outside cytochrome P450 system, and we all know them. And in USMLE, we used to learn this OLT, out the liver, and which is oxazepam, temazepam, lorazepam. And we will talk about lorazepam in few minutes as well, temazepam for sleep, but keep these medicine in mind if this interaction is coming into picture. But I will stop my sharing again. Perfect. So that's the basic overview of cytochrome P450 system.
Excellent. I remember that acronym in our USMLE prep, and so it's so helpful to go back and review these basics because, like you said, we often forget these things that we learned in residency, yet they're still clinically relevant. So we have a patient in front of us now, and we've done this risk-benefit analysis. We've decided that, okay, this patient might be appropriate for a taper. What signs do we look for, and how do we even talk to that patient to see, okay, first of all, do they have buy-in to the taper? How do we set expectations? What's the next step from a clinical standpoint? As you can see, there's a lot to learn when it comes to clinical sleep medicine, and we're just scratching the surface in today's interview. If you are a physician or a health practitioner who wants to learn more about clinical sleep medicine in a practical way that you can use in your everyday clinical work, then get my free sleep mini course. I'll put the link to that in the video description below. You can also get it at intrabalance.com/doctors.
Yeah, that's the I think experience, right? We all get with every patient. But the biggest message I will say from the guidelines and from my own personal experience is this is not one size fit all approach. So it has to be individualized. That's number one. And number two is we need to validate and normalize their concerns first of all. And I say this like all the time to my patient that this is not me saying everything. It's a teamwork in the end. We have to work together. And I call this an opportunity to my patient that this is not something bad that will happen right now that we will talk. This is an opportunity for both of us. For me, it's an opportunity to talk about the benefit and risk of continuing versus taper. And this is an opportunity for you to tell me how this is impacting your day-to-day functioning. So the team process is the major way to approach that and normalizing their concerns. And the most important thing is, which I have learned through difficult experience, is setting a realistic expectation in terms of how we will do it and how we will pivot if things are not going well. But I'm here for you. We will do close follow-up if needed, and you can reach out to me. We have a messaging system in our practice or calling me. But once you tell them that we are here together in this process and we will work on it, and this can even mean doing it for years sometime, because I have like patients who are on this unfortunately for 30 plus years right now. And I think this is the dark side of these guidelines. Patients are being referred to our practice from other specialties to taper them quickly, especially if they are on opioids. So setting those clear expectations, telling them that this is a team process is the first way to start that.
I agree with that completely. And like you said, validating their fears, it goes a long way because patients, many of them don't want to be on the benzo. Like I see a lot of patients like that where they don't necessarily want to be on this medication, but it's helping them. And they have fears about going off. They've experienced withdrawal if they missed a dose here and there. They don't want to feel that either. So I think bringing some compassion and empathy into the approach is a really important first step not to miss.
No, 100%. I just want to say something. You said something very clinically relevant. And once I read these guidelines, they mentioned briefly on that many physicians even feel uncomfortable talking about this because we all remember the difficult experiences with our patients. So most patients get very angry, like when we even talk about it. But it's amazing. Many patients even feel relieved when a physician, when a medical health professional talks about maybe we should taper it. And I have personally seen that. So I think we have nothing to lose by starting that conversation.
I totally agree, and it reminds me of a patient that I saw when I first was out of residency, and I was working in outpatient practice, and this woman had been on Xanax. I think she was on, like, 1 milligram TID, something like that, 3 times a day, and she'd been on it for years, and I was like, "Oh my god, like, I need to get her off of this medication," and there was a lot of resistance, but we talked
Yeah,
about it for a long time. It took a few months to build a rapport with her, to get her
100%.
to the point where she was ready to taper, and then over the course of, I think it was 2 years,
Yeah.
we got her tapered off, and she did great, and she was so grateful and appreciative throughout the process, but we need to have that patience within ourselves that this is gonna take some time.
And I agree. That good feeling when you get when patient talks about it, I always remember that and use that when we are about to discuss that with our next patient. 110% agreed.
We touched on some of the misconceptions earlier. What are some of the common mistakes that you see when it comes to tapering benzos in the clinical setting?
I think we talked about them briefly. The number one is that it has to happen right now and in the next few weeks. Tapering too quickly is the number one mistake anyone can make. And second is failure to set the right expectations for our patients. And then not addressing the comorbidities. This is, I think, the biggest thing I have felt is a reason for actually treatment resistant for any condition we see, even for major depression. If you fail to, like for benzos, if insomnia is not taken care of, if anxiety is not taken care of, if comorbid prescriptions like opioids or substance use disorder is not taken care of, that's a recipe for failure. And the last is, which is I think for very easy for me to say right now, but it's very difficult for many practices, is to have a more close follow-up. Many patients get lost to follow-ups and they end up going to another doctors and they get labeled as drug seekers. I have seen that unfortunately a lot. And the practice, most of us see people in 15 minutes. Thankfully, we get more time, but sorry, I'm getting distracted again, but that's the major downfalls where doing it too quickly, not setting expectations and not addressing the comorbidities and not seeing them with close follow-up, especially initially when we have started the taper.
So I'm curious, when you're working with someone, with a patient in your practice, and you're gonna start this taper, what is your general approach to designing that taper plan and follow-up and all of those things? How do you approach it in your practice?
Again, it's not one size fit all for the patients. My first approach is to assess if a patient is at risk of dependency or not. It all comes down to that, in my opinion. If a person is at risk of dependency, that means they will have higher risk of withdrawal, and that means they will need more close follow up, maybe on a weekly basis, or sometime I even have my medical assistant check with them via phone call as well. So it all depends on that. And it can never be like, okay, we are doing 5% taper. The guidelines talk about how many percentage to go down on, but you taper first, assess, and this becomes your new dose and go down accordingly. Increase the follow-up if needed. So there's no one model that we can choose, but we can spend some time on physical dependency right now because the guidelines talks about first risk and benefit, and based on that, if taper is needed, if you decide if taper is needed, then you need to assess the physical dependency status. And I can very quickly share my screen. As we talked about, if risk outweighs benefit, you need to assess if a patient is likely to have physical dependency. And physical dependency is what will decide if you taper slowly or you do a sudden discontinuation. And this is done using, this is a table actually from guidelines. I have just modified it a little bit. We look at these three factors. I will talk about these three factors, which will help us assess their dependency status. And these three are duration of benzodiazepine usage, how long they are using benzos for, Second, frequency. How often, how many days a week they're using benzos for, and their total benzodiazepine dosage. And this will help us assess their withdrawal risk. So I will go over this very quickly. And this was actually, let me go down on this. CGC is the committee that was assigned for this guidelines. They all agreed that these are very important factors in making that determination. But going on to that, if a patient is using any benzodiazepine, it doesn't matter. And the frequency is less than half days of the week and dose don't matter. But I think this was very important factor for the guidelines. If they're using half days of the week, then the risk of withdrawal is low. But as soon as the frequency goes more than half days a week, dose don't matter here. But if the duration is less than 1 month, still the risk is lower, but possible. Obviously, there is no clear-cut guidelines in terms of who will withdraw and who will not. And as soon as the duration goes 1 to 3 months, more than 1 month to less than 3 months, and the total benzodiazepine dose is low. I will talk about what low means in a few minutes, but even now the risk is low, but still possible. And the next is these stay same and the total benzodiazepine goes to moderate to high. That's where the withdrawal risk goes up. And the last is if the duration goes more than 3 months, the risk goes up. And to make it more easy, I have actually made these things in blue. This is what I personally focus on. First, I look at the duration. If duration goes beyond 1 month, I look at how often they are using it for. As soon as it goes more than half days a week, then I look at moderate to high benzodiazepine dosage. That is what will help us assess if they are risk of dependent or not. But you will ask, what does this total like low, moderate, and high benzodiazepine dosage mean? This is actually from something called diazepam equivalence. And that is what defines low daily dose, moderate daily dose, and high daily dose. And if any medication is 10 milligram or less than of the diazepam equivalent, that's low. And if it is 10 to 15, that's moderate. And more than 15 is high. So the question comes, what are these diazepam equivalents? And this is where more confusion happens because guidelines recommended these two conversion tables. I mostly use Ashton manual, which is very old manual published in 2002, but the most recent guidelines were published by the VA DOD committee. And you can see it's so much variable. Like the 10 milligram of diazepam is equal to, this is how they convert it. But you see here, clonazepam, 10 milligram of diazepam is equal to 0.5 milligram of clonazepam per Ashton manual, but 1 milligram per the VA guidelines. But I don't think it even matters because what I found was all these conversions were based on not clinical trials, like not randomized controlled trials and everything, but they were based on the patient's clinical experiences. So Ashton manual, I know they looked at so many patients' clinical experiences and came up with this one. Same goes for the VA guidelines. So that emphasizes the importance of considering a patient experience. And I don't think we can do that without a collaboration approach. Anytime you push a taper, the withdrawal will go higher and you have lost the battle there. But let me stop my sharing again. Perfect. So we are back.
That's really helpful and so interesting to know that it's based on the patient's clinical experience and not the pharmacology itself of the medications.
Yeah, I didn't know that actually. The guidelines recommended talked about that briefly. So this was a new learning for me as well.
Yeah. Okay, so now we've talked to the patient, we have their buy-in, we have an understanding of their risk of withdrawal, the type of dosing that they're on. Is the recommendation to use a long-acting benzo to taper? I know there's that approach that some clinicians will sometimes use. Or are we working with what they're already on and simply reducing the dose? What do the guidelines say about that?
Guidelines were clear, but also not clear on that in some areas. If I have to summarize that briefly, guidelines says after you have assessed the dependency status, the next question comes is if a patient is a suitable candidate for long-acting benzodiazepine. If not, then you just do the taper based on their guidelines. So I may have missed a few slides, so let me share my slides again to answer that question. So like we talked about this, if a patient is at not risk of dependency, you do the taper. And if patient is at risk of dependency, you do a slow taper. It can be done in outpatient setting for most people, but if not, you can do inpatient setting. Let me share my screen again. Perfect. The question comes about is the long-acting benzodiazepine. Now, keep an eye on one thing here. You see this conditional recommendation. This is not a strong recommendation that you have to apply this to every patient. This is a conditional recommendation. You need to assess if a patient is the right fit for that or not. So guidelines are recommending that you may consider switching to a longer acting benzodiazepine, the comparable dose, for patients without contraindication. Now, this without contraindication is a very big topic. And the reason for that is the committee that did this guidelines, in a big picture, they disagreed that you should switch every patient on short acting benzos like alprazolam to a longer acting benzos like clonazepam or diazepam. But they recommended that if you need to do that, you need to keep an eye on one thing. That patient do not have hepatic impairment, because most of the medication goes through the liver with the impact on 3A4. And in those cases, if you want to do it, please prefer lorazepam. And the big risk population group was our older adults, because in older adults, the longer acting benzodiazepines can get accumulated very easily and thereby increase the risk of sedation, fall risk, cognitive impairment, and many more. So the guidelines recommended, this was the basic summary, that if you decide to switch to a longer acting benzodiazepine, it should be patient specific, and you should do a baseline liver function test and look at their other medication so that there is no drug interaction happening before switching them to longer acting benzodiazepine. Now, let me stop the sharing on that. So that is what the guidelines say. So it was not very clear cut, but it was not a strong recommendation per se. Now, personally speaking, we switched to longer acting benzos. Guidelines recommended 3 benzos that you can choose if you need to switch to a longer acting benzodiazepine. First was diazepam, second was clonazepam, and third was chlordiazepoxide, which we mostly use for alcohol withdrawal mostly. But the first 2 were like the biggest one. The guidelines also talked about phenobarbital, which was a very big if per the guidelines. And they say if it has to happen, it has to be done on an inpatient setting to begin with, later transitioning to outpatient. And ideally, it has to be done by a professional with, I think, addiction medicine fellowship, or they should be available for consultation. So no clear answers on that, but once you look at the flow chart, after the physical dependency, if you do taper, the flowchart goes to assess for long-acting benzos first before doing the taper.
That's really helpful, and I think, again, it speaks to how nuanced this process is and how personalized it is for each individual patient and their comorbidities, what other meds they're on, their age, and so many other factors. So you mentioned before that when you do the taper, now this new dose is their baseline dose now once you get to the next step. So how do you determine how long to stay at each level? Do we pause? Do we wait? What's the process, and what do the guidelines say about that?
So let me open that slide so that we start on. Perfect. So let me share that. And again, this is actually, I will talk about that. I think our last discussion will help with that. Understanding the tapering process, this was their 6th recommendation in this guideline. So if I have to just summarize everything in one slide, this is what they say. You start with 5 to 10% dose reduction. Like that's the 5 and 10% for visual representation. And the taper pace should not exceed 25% reduction every 2 weeks. And this is actually based on the guidelines, or not the guidelines, the randomized controlled trials they reviewed. They found as soon as any of those trials went above 25%, the dropout rate increased. So this was a basic overview. But as I mentioned before, there is no one size fit all. So the question comes, what should we do? Should we start with 5%? Should we start with 10%? Is this the right percentage for every patient? It's not. And this is a strong recommendation, just to point that. The numbers will depend on their dependency status again. And let me go to that. So first we assess their dependency status based on this that we just talked about. Now, if a patient is a higher risk of dependency, you start at lower end, like not 10%, but you start at 5% and you go super slow every 6 to 8 weekly. Personally, I go every 6 weekly for my patient, but some patients who are on it for 20, 30 years, I even do 8 weeks, depending on how much they can tolerate. And then this is still on the high dependency patient, you reduce further more slowly, 5 to 10% every 6 to 8 weeks. So here you're not doing 25% reduction. So 5% to start with, and then 5 to 10% every 6 to 8 weeks. But patients who are low dependency risk, there you can do 10 to 20% reduction, and you can start with even 5 to 10%. And one thing I liked about these guidelines is they gave so many examples that we can use in our daily clinical practice. And one of the example actually I found very beneficial for a few of my patients recently is most patients will be anxious when we talk about this. So you just give them a 5% reduce, just one dose to assess how they feel. Because we feel confident when we experience something. So we need to give them that good experience before we can taper more. But coming back to this topic, so these three things, right? Duration of benzo use, frequency of benzo use, and total daily benzo use. These are top three criteria we look for dependency status, but there are other variables we need to keep an eye on when we are doing these tapers. So first is the dose, like this one we already talked about. Obviously, benzos with shorter half-life, and they are specifically talking about alprazolam, Xanax. There's a sharp decline in benzodiazepine receptor occupancy, highest risk of withdrawal. The guidelines talked about alprazolam being the worst. That's the message I got after reading it. Ideally, we should avoid alprazolam as a first line because the risk of withdrawal is so high. And even that protracted withdrawal syndrome that I was talking about, the risk is higher with shorter half-life benzos. One of them is alprazolam. Sorry, coming back to this. So first is benzo dose and half-life. Second is their frequency and duration that we talked about. But the other factors are co-occurring physical and psychiatric condition that we talked about. And also their response to previous missed doses. That can tell us so many things, how much withdrawal risk they are at. And also their response to benzodiazepine tapering attempt, patient concern and anxiety. And actually this is what I just mentioned. But one thing I have not mentioned here written in this slide is guidelines also mention, also look at their, if they have history of alcohol dependency and alcohol withdrawal, look at their history of alcohol withdrawals in past. If a patient is at higher risk of withdrawal in past, their risk for benzodiazepine withdrawal also increases. And again, always consider which dose to reduce first. This is, I think, very clinically relevant. If insomnia is a concern, you reduce the earlier doses first. And if anxiety is a concern, you reduce their later dose. But let me stop the sharing. But this is a basic overview of the taper. I'm just going fast right now. We have so many more slides. Otherwise, we will just stay here for, it's a 2-hour course right now. So
It's a fantastic course. I'm already learning so much. So we'll link to the course below. So if you're watching and you're interested in taking the program, you can sign up for the course using the link in the video description. All right, so this was so great. We have an initial pace, 5 to 10% dose reduction. We're basing this on the patient's risks of dependency. From a practical standpoint, how are we doing a 5% dose reduction? Are we using a compounding pharmacy? Are we using a liquid formulation? What strategies can we consider for that?
yeah, I know we have like a different section in course for that. So guidelines were very straightforward with that it's good to know the 5%, 10% rule, but in clinical practice, it's very difficult. Not every benzodiazepine can be done with the 5 to 10% rule. And compounding pharmacy is an ideal answer, but compounding pharmacy is so costly. That's what they mentioned. That's it. They did not, they just said they wish that pharmaceutical companies makes more dosing available, especially because it's not at the initial one, in my opinion. It's mostly when you're reaching the end of the taper, that's where we need to go more lower. Thankfully, we have a compounding pharmacy where we work, and it's very, very patient friendly. They work with patients in creating those liquid drops. And guidelines talked about those liquid drop formulation, but it's not feasible for every patient to do it correctly as well. I know Netflix had a documentary last or 2 years ago where patients talked about using those liquid drops. But yeah, that's the only thing I will say. But we all know it's very difficult to do 5 to 10% reduction ideally.
Yes. Yeah, absolutely. And I think there's room there for creativity to figure out different ways to do it and depending on what medication the patient is on. And I really liked the idea of the test dose, just doing a test of 5% less. Let's try that and give them that confidence that, okay, I can handle this. And that's such an important part of the buy-in process.
Yes, yeah. I always say you have nothing to lose and you will have good supply for a month or 2 weeks. So even if you go down, you will still have the medications to go back to. I think that plays such a big role improving their confidence in the process.
In terms of adjuncts to the taper, cognitive behavioral therapy could be an option. What other options should we consider? Are there supplements, other types of medications? What's recommended?
So yeah, that's a very good point. You mentioned CBT because when we talk about adjuncts, everyone thinks of which medicines to add right now. So I will share my slides in a minute, but guidelines were very clear. They actually divided this into two. First was interventions, and second was medication. I will talk about intervention in a minute, but in terms of medication, guidelines were not supportive of medication as an adjunct. They specifically mentioned Cochrane review and two other big RCTs that were done, and they found that adjunct medications were not, they didn't have a very good effect size to show the response. And they specifically mentioned three medication in these guidelines. First was Buspar, which I use a lot for this. They found Buspar to be, what is the word, not that beneficial. And the second, they looked at carbamazepine, Tegretol, and they said very limited evidence. And third, which I use more than Buspar for my patient, is gabapentin or pregabalin. They were like, if you ever go to gabapentin or pregabalin, it should be your last to last resort because of the risk of abuse and dependency on that as well. Because I use gabapentin a lot because Mayo Clinic came up with their new guidelines for alcohol withdrawal in an outpatient practice. But this was actually an eye-opening for me to be cautious of going to gabapentin. Now, going to the other interventions, let me actually go to that slide so that we can, okay, perfect. Now let me share my screen very quickly. This was the 10th recommendation per guidelines in terms of interventions and referrals. So this was a strong recommendation, although with the low certainty, but this has to be given to every patient per the guidelines. So they are saying that behavioral intervention should be tailored to the underlying conditions a patient is on. If a patient have more comorbid depression, anxiety, CBT is just an example, but they are recommending any style of therapy. And this is more of your area, Nishi, like CBTI for comorbid insomnia. And if you don't have expertise in any of those, then they're recommending that you should do a referral. And this was based on these studies they mentioned in this guidelines that patients who were doing gradual taper combined with these interventions, they did much, much, much better than who did just gradual tapering alone. And they mentioned this big review published in 2015. Patients who did CBT with benzotaper, they had higher success of discontinuation at 1 month and 3 month mark. And I'm sorry, let me go back. So this was a very basic overview of the interventions they are recommending, targeting the comorbid conditions which can make it more difficult for patient to stop.
That is so interesting that the Cochrane review with the outcomes long term with discontinuation and the behavioral interventions. And that kind of leads to our next topic, which you've touched on already. A lot of patients struggle with sleep disturbances during these tapers. That's my specialty, is supporting patients with those things. You mentioned CBT, cognitive behavioral therapy for insomnia. Any other thoughts on how to manage those sleep disturbances?
I think you should talk about that, not me, but yeah, they did not mention anything new with sleep disorder. I know we have a slide, but I will just very briefly mention that they just mentioned all what we need to do for sleep hygiene. So sleep hygiene was a very big factor in those guidelines. That is what I will say. And actually they mentioned if safely, like polypharmacy is not a right thing for these guidelines, but for a short course, if you want to add something for sleep while you're doing a taper is a very big thing, like trazodone or doxepin or something else, which don't have addiction dependency potential. But that's what the guideline says. But personally speaking, sleep is a very big thing for me. I always tell my patients, if your sleep is not good, then it will either not work or it will take longer than usual time to get better. I just give them 2 to 4 week course of any sleep aid, and we have a very big printout for sleep hygiene, and I just make it like a must for them that if you don't follow this, then it's not a teamwork and we are just not, let's accept that we will not get the optimal response. Sleep hygiene with a short course of medication, I think, is the way to go. But I think you should talk about that, Nishi, more than I do.
Sure. Yeah. And I'll just add to that. I think, yeah, sleep hygiene is a great foundation. And then have a low threshold to refer to cognitive behavioral therapy for insomnia, because
Yeah.
it really is about helping patients rebuild their confidence in sleep. We were talking about their confidence with tapering off the medication. With insomnia, a lot of it is just rebuilding their confidence in their relationship with sleep and using a very slow taper protocol to get off the benzo, or sleep aids are outside of today's scope. But CBTI, and in our practice, we blend it with ACT, which is acceptance and commitment therapy. And there's excellent outcomes with that. And so we've helped so many patients be able to taper off their sleep aids using that approach. So I'll put the link below as well. So if you're listening and you're looking for more support for your patients, we do have a sleep coaching program. So I'll put that underneath if you're looking for more help. I think by now, the doctor, nurse practitioner, whoever's listening, I think they have a really good idea now of where to start. You've presented this information so wonderfully and it's so clear. But for the clinician who's listening and they're still stuck, they've got this patient in front of them, what would you suggest as the next step?
I think everyone must have received this message by now, but my biggest message to everyone and even to myself is please do not rush. It's okay to wait till your patient is ready. Take your time on building that relationship with your patient, and always start with the risk and benefit analysis first, followed by assessing their dependency status and then going after their comorbidities. And I'm just summarizing this in it's not that simple, but this is the basic overview that we all can go after. But the number one thing is the patient relationship and work with your patient. And it's not one size fit all approach.
You've just presented this excellent framework based on the ASAM guidelines. And I know you have a course as well. I highly recommend, if you're listening and this topic is relevant to your practice, go and get the course. You just got a small sample of it today, but already I've learned so much. So I know it's going to be jam-packed with useful information. But what other tools, frameworks, or resources do you recommend for clinicians to navigate this process of benzo tapers?
I think we should always go at the source rather than reading somewhere else. I personally go to ASAM website, and I will recommend please read if you have a time. I think it's 400 plus pages of guidelines they recommended, but it's pure clinical relevance in my opinion. ASAM also provide those patient handouts that I provide to my patients. So I will just recommend go to ASAM website. It's free. But if you don't have time to read those much, please join our course. It's a 2-hour course though, divided in 4 sections. And I've tried to make it faster, but it's not possible to make it smaller. And it's actually mainly, I created this for our Academy members, which is free for them. But not everyone is interested in Academy membership. You can just go to psychiatryeducationforum.com and read more details there.
Where can people work with you or find out more about what you offer?
I will recommend go to psychiatryeducationforum.com. The website is confusing because we have so many options available in the website. But the website is mainly Academy membership, which is renewed on an yearly basis. It's for all the medical professionals, ranging from physicians to nurse practitioners to physician assistant to pharmacists right now. But it's only for medical professionals. We have, I forgot how many 100 chapters right now, but they are divided into journal clubs clinically relevant topics and these guideline summary. And then we also do question and answer session with primary care physician. We have my wife, Dr. Kaur, she sometimes comes and do those sessions with us. But there is so much happening. It may sound confusing. Just watch the video on the homepage, but that's where you can find me. There's a contact us button. My email is there. Just email me if there is anything I can help you with.
Great. We'll put all of those links in the video description, so go check it out. What an excellent resource. And I love those kinds of formats too, because you get to learn from your peers, which we're missing when you leave residency and you leave training.
Yes, we have a closed Facebook group right now for the students only, and that's very helpful right now.